Did you know that most women's health or gynecologic issues are usually not all hormones and a lot of insulin? Now, let's just start by talking about what insulin actually is. The way I like to describe it to my patients is that glucose is the thing that we consume, and insulin is your body's hormonal response to that thing. And so, if you were to eat a meal, breaks down into glucose. That would cause the pancreas to make insulin. Insulin then goes to the cell and, for lack of a better term, opens up the door so that that glucose can go in and we can then use that for energy. And insulin is actually one of the most powerful reproductive signals in your body. Did you know that we have receptors for insulin on our ovaries, our uterus, our pituitary, our thyroid, our fat tissue even? And so when we have chronic insulin dysregulation or dysfunction, this can disrupt so many processes. This can disrupt ovulation. This can be a contributing factor to fibroids, infertility, and this can even worsen your perimenopause experience. So let's get into it, starting with infertility. Now, a lot of people think that infertility or missed periods is literally just about, not having a period or, having a hormonal imbalance. But the reality is you can actually get monthly cycles and not ovulate. Sometimes we see this in postpartum, but we also see this in PCOS. In PCOS, up to 80% of people have an insulin-driven hormonal imbalance. What does this mean? It's that they have insulin resistance, and when we have insulin resistance, this doesn't allow our body to ovulate properly. Now, if we look at the menstrual cycle, we need to ovulate in order to make progesterone. If we do not ovulate, we, first of all, cannot get pregnant. And second of all, do not make progesterone. We need to make an adequate amount of progesterone. High insulin causes our testosterone to rise, which is also part of the reason why ovulation is suppressed. We know that low ovulation equals no progesterone. And this can explain PMS symptoms, but also infertility. If you're not ovulating, you cannot get pregnant. Now, it's interesting because PCOS is more of a syndrome rather than a specific diagnosis with a specific number of symptoms. A lot of people present differently, but we know that the bulk of women have some sort of insulin dysfunction that drives the syndrome. Symptoms appear: acne, hair growth on your face, hair loss on your head, weight gain, cycle issues, but some people do have a regular cycle and still have PCOS. We also know that fibroids are strongly linked to metabolic dysfunction. And the reason for this is insulin does a few things. It activates growth signals, which is going to cause that growth. It's going to drive inflammation. It is going to impact blood flow changes to the uterus, which is going to impact how our uterus interacts with the growth of things like fibroids, but also, coming back to fertility, things like implantation. We know that insulin increases estrogen activity inside fibroid tissue. And we also know that fibroids worsen with low or inconsistent progesterone, which we've also spoken about with the lack of ovulation. And fibroids also worsen with unopposed estrogen, right? Estrogen that doesn't have any progesterone to counteract its effects. And how we're going to get that is insulin disrupts ovulation. So indirectly, this also worsens fibroids. When we look at heavy bleeding, polyps, and endometrial overgrowth, we know that the uterine lining thrives on estrogen, but it needs the progesterone to help regulate growth. If we have insulin-resistant cycles, we typically have higher estrogen relative to the progesterone, and this can indirectly stimulate endometrial proliferation. This can indirectly stimulate the growth of the lining of your uterus, which can show up as heavy bleeding, spotting between cycles, hyperplasia, too much lining growth. This is why in someone with PCOS, we will often induce a bleed if they haven't had a period in a long time, or they might do an ultrasound to evaluate the lining of the uterus to make sure it hasn't gotten too thick, because we know that cycles without ovulation, whether you bleed or you don't, can actually increase the risk of endometrial hyperplasia, which we know is obviously a higher risk, much higher risk if you are not bleeding versus bleeding. Now, the emerging concept that I'd like to chat about is called progesterone resistance. So this is in a scenario where progesterone is present, so we are ovulating and we're making progesterone, but it's not effective. So when we have insulin resistance, it's not going to consistently and always suppress our ovulation. It certainly can, and this is a pattern that we see in a lot of PCOS, but when insulin is there, again, if we talk about how insulin resistance develops, essentially what happens is we are breaking down food into sugar. We are then making the insulin so that we can, store that sugar. And so what happens is over time, I always describe this to my patients as if you ask your kids to do something and you keep asking over and over and over, and then they just tune you out, right? The cells just start tuning out insulin. They're not listening to the signal. And so then our body goes, well, I guess we have to make more insulin. We make more and more, and we end up making more insulin than we need to do the same job. Eventually, the system just breaks, but our body has a really great way of compensating until it no longer can. And so when we create this insulin resistance, what happens is ultimately our cells are, for lack of a better term, being bathed in insulin for a large amount of time. And what that results in is, our cells not having proper signals for other hormones. And one of the things insulin can interfere with is actual hormone receptors, one of those being progesterone receptors. We also know insulin can interfere with implantation readiness, cellular repair, right? And so indirectly, insulin has a really big role hormonally on impacting how things actually function, even if they're there. Because you're like, but Laura, I ovulate. I've tested my progesterone, but in the presence of too much insulin, it's not going to work how we want it to or how we need it to. And now we know that perimenopause actually makes all of this worse for a number of reasons. We know that insulin resistance increases with age because of the hormonal shifts. We know that as estrogen becomes erratic, that impacts our inflammatory responses, that impacts our insulin. And so that can make that predisposition to insulin resistance worse, or that, that those lifestyle choices that were leading to poor insulin regulation are going to have a much larger effect as we get to perimenopause. Again, it's partly because estrogen fluctuates wildly, and so we really have our insulin sensitivity fluctuating as well. We also know that progesterone becomes inconsistent in perimenopause, which can further worsen this spiral. We know the thyroid is more vulnerable. We have these periods of life that are referred to as a transitional chaos, puberty, pregnancy, perimenopause, where you're more likely to have autoimmune diseases because our immune system and our hormones are interacting in a way that they really didn't interact in previously. And so because of this, we have more autoimmune diseases, and the thyroid tends to get hit most often in women. We also know that in perimenopause, because of all these things, we have heavy bleeding, inconsistent bleeding, fibroids, maybe polyps, etc. And so what can we actually do about insulin resistance? I personally love a personalized approach where we're doing an insulin glucose challenge. We're understanding what your insulin patterns are specifically, and we're mapping that out. But understanding your patterns is really important. The insulin pattern can determine whether or not we're going to do intermittent fasting, 3 meals, no snacks, whether we remove certain insulin stimulating foods, protein and fiber with meals. How do we determine how much? How do we know where to get our fiber sources? What fiber is better for blood sugar? What fiber is better for gut health? How do we find the specific types of fiber for us? We know that strength training is really important. And we know that reducing your chronic stress load is really a key component. And so I am hosting an educational program for women called Her Metabolic Confidence Lab. We are doing this in 2026, mid-January. So make sure you join us. You're going to learn everything you need to know about these metabolic systems that are driving your hormonal symptoms. This is what helps us actually get to the root cause and actually make changes and advocate for ourselves in ways that support our overall improved hormonal function. If you want to get on the list, comment in this video below or head to www.laurapipher.com/hermetabolism and register. Early bird pricing ends January 1st. We start mid-January 2026. Don't miss this. Spots are limited.